Yeah.
Hi, I'm Sam Christie. This is my RSI assistant, Oski. So I've been called out to a 40-year-old male who has fallen off his roof 6 meters high onto concrete, landing on his occiput. So first of all, I'm coming onto the scene. I'm going to make sure that both myself and my crew member are safe, also the safety of my patient as well. So as I approach the scene, I'm having a look at my patient and getting a general impression for the scene and the severity of the incident. So having a look at him, I can see that he is flexing and extending, he's posturing. And yeah, so I'll go from there. So hello, can you hear me, sir? Yep, so I can see that he's obviously breathing. He has no response for me, he's just moaning and groaning. So I'm gonna get Jacob to do a rapid trauma assessment while I survey his primary survey.
Right here, there's a big bulging kind of soft spongy patch there.
Any blood, major deformities. So I'm feeling his pulse. His pulse feels strong but very weak, bradycardic at this stage. So I'm going to have a look at the mushiness in his airway. Okay.
So nothing turned up on the rapid trauma apart from the spongy patch.
Okay, sweet. So at the moment we're looking at an isolated head injury due to the posturing and tensioning. He could have a lower GCS, so I'm going to assess that. So his eyes are closed. So hello, can you hear me? No response to pain, no response to voice. So voice is 0. He has moaning and groaning and incomprehensible sounds, which is a 2. So we've got 3 so far, and he's posturing and extensing, which is either 2 or 3. So we're going to go for a GCS of 6 or 7, which is indicated of RSI. So Jacob's doing a full set of vitals for me at the moment. So at this stage, with his irregular breathing and his lower GCS due to a head injury, we're going to be calling R50 for RSI airway management.
Right, so I've got a hypertensive blood pressure about 200 over 120. Got a slow bradycardic pulse, irregular respirations, probably about, I'd say 20.
Okay, sweet. So at the moment my patient is presenting with Beck's triad, so I'm going to get an IV in and we're going to start doing my RSI preparation. So Jacob, if you want to position the airway and put a towel on his head, ET tube and suction.
Right.
Cool. So do you understand that?
Yeah,
Are you comfortable?
Towel, ET and suction.
Because my patient is appears to be combative a little bit, moaning and groaning and tensioning and stuff, I'm going to be looking at giving some morphine under the combative patient scheme. So I'm looking at his arms. I'm also going to get into preferably 2 IVs for fluid management as well. Thanks, Jacob. So I'll swab the area. Looking at it, I've got my IV gear ready to go. So Sharp's live.
Right, Sam, ET, towel and suctions there. What next?
Can you get a reservoir mask out and place it on at 10 litres per minute, please?
Yeah. So we don't actually have a reservoir mask, but we'll just use this.
Sweet, so I've got that. Sweet, so my IV line is in and secured. I'm going to give morphine. Can you just drug check that for me, please?
Yep, so morphine, 10 mg 1 ml in date.
Morphine, 10 mg 1 ml in date. Sweet. Sharps. Live.
Right, so that reservoir mask's on at 10 litres a minute.
Can you please get the BVM out? Attach PEEP.
Yep.
Capnography. Is that done?
Yep, so that's all ready.
Okay. So now that you've done that, can you get the nasal prongs out? Place it under the patient's face, but do not attach them to the oxygen.
Yep.
So we have oxygen running. We want to make sure that the patient is adequately oxygenated. We want to make sure that they have fluids running as well. So the fluids have been spiked, Jacob, and ready to go?
Yep, so that's sodium chloride 0.9%, 1,000 mils, and it's in date, and that's all good to be go.
So I'm going to give 2 mg of morphine under this combative patient, Zach. Sweet.
Nasos are on but not plugged in.
So how is my patient now after the morphine? Are they adequately sedated?
Yeah, they appear to be sitting down a bit. There's less grimace, there's less inflammation.
Flush that through. Sweet. So sharps are done. Okay. So where are we at? We'll get my fluids running, and we'll get, the neighbor was here. She called 111. She's got a Zimmer frame, so she can't help out, but we'll get her to hold my bag of fluids up for me. Cool. So I'll open my bag up, run it. Sweet. So because this is a mannequin and not a real patient, I can't put an IV in the other arm, although preferably I would put an IV in that arm as well, a large bore in the ACF, and possibly look at running more fluids, however the blood pressure and stuff is good. Sweet. So Jacob, do you want to see how far away my ICP is? Do you want to go to the truck? Is there anything else that you think I should be doing at this stage?
No, I think we just start tidying up and arrive.
Okay, do you want to start tidying up, and I'm going to go through my RSI assistant checklist?
ICP is 2 minutes away.
2 minutes. Okay, so looking at my checklist, we have nasal prongs attached but not done. I'm pre-oxygenating with the reservoir mask. We've attached monitoring. We've got SpO2, ECGs on, and blood pressure. You've gone, do you want to do another full set of vitals as well?
Yeah, I'll just tidy up.
End tidal is on. Position the monitor so that it can be seen moving space at the right of the patient's head. So do you mind just tilting that so that the ICP can see it?
And that blood pressure again.
Okay, sweet. So we've got 2 IV places. I've prepared a running line of sodium. We've got a folded towel under the head with an ET holder strapped under it. We've got suction right there. We've got a manual ventilation bag there with a PEEP valve attached. We've got a full set of vitals that Jacob's doing now.
That second set of vitals comes back the same.
We just need to prepare the area, make sure it's as tidy as we possibly can. And because the ICP is close, we're not going to think about getting the patient into the ambulance and moving towards them. Sweet. So what we're going to do now is we're just going to have a quick tidy up, make sure the scene's all nice and ready to go for the ICP, which it is, and everything's sweet. Okay. So from here, if my ICP arrives, he might want me to do procedures such as BERT, which is backwards, upwards, rightwards pressure. So that helps with the intubation process and visualizing the vocal cords. He might also want me to bring the bougie out of the ET tube, and he might also need me if there's a failed intubation. So what he could do in that case, I'm going to take over manual ventilation while he prepares to have another go at intubation, where he changes something. Something has to be changed, whether that's the size of the ETT tube or not, and then he'll have another go. If that fails, we'll take over and we'll just do an LMA or an alternative airway device. And if that fails, we might even look at cricothyroidomy, which I will help assisting that as well. Sweet.